This patient received what I think was a very appropriate workup. For most of my patients, I typically will obtain a PET CT scan, which will give me the best sense of the stage of their disease. It also provides measurements to help me identify whether or not a patient has bulky disease, which is something else that we take into account. I typically do not require my patients to have a bone marrow biopsy unless there was some specific finding in their blood work or something else going on that made me wonder if there was an alternative process going on in the bone marrow. Otherwise, most of my patients, I will recommend HIV screening if they haven't had it already, as well as assessment of their baseline kidney and liver function to help inform whether or not they can tolerate therapy. Finally, for patients where we're considering bleomycin, I also will require patients to have pulmonary function tests performed, and for patients for whom we're thinking about giving adriamycin or other anthracyclines to, we'll typically do an echocardiogram as well. Most patients receive a very appropriate workup, at least when they come to see me for an opinion. The only thing that I think is probably done more often than it might need to be is the bone marrow biopsy. This has historically been a standard part of the lymphoma evaluation, but what we found is that that it's infrequent that the bone marrow biopsy truly alters the way that you approach a patient. In addition, in Hodgkin lymphoma, bone marrow involvement is not particularly common, and so in most cases I don't feel like that is necessary. There are a number of factors that I take into account for every individual patient when thinking about what treatment is appropriate for them. Certainly our goal for most patients is to try to cure them of the disease, and we want to do whatever we can to increase the rate of cure, but that's not always the only consideration. In patients that have underlying lung disease, in elderly patients, or those that have other comorbidities, we may need to change our treatment, even if it does mean that their likelihood of cure is a little bit lower. In most patients, however, where we are going to go for a cure, we try to treat patients with the most aggressive, appropriate regimen. There's an ongoing challenge when selecting therapy for any lymphoma patient where you're trying to balance the efficacy of the regimen as well as its safety. In my opinion, for a disease where you're trying to cure the patient, I'm typically willing to sacrifice a little bit of toxicity for a significant efficacy benefit. And that's typically where I start from for each individual patient. Certainly there may be patients that simply can't tolerate the most effective regimen due to some other underlying comorbidities, and that's something that we deal with each patient on an individual basis.